just get started a little bit because we have quite a few
Okay.
people here now. But hello guys and welcome back. We are so excited to have you guys back. I don't know if you guys were just listening in, but we were just talking about the inauguration and stuff that's been happening in our country. And I just wanted to address a few things before we go into the session. Not about the inauguration, but about Club Med. But so we, if you guys are like watching this session, in order to get a certificate for the session verifying your attendance, we just ask that you guys sit through this whole session and then write a summary paragraph. Nothing special, 4 to 5 sentences, covering everything that we talked about, just a broad overview, and email it to clubmedshoot@gmail.com. And we will send you a certificate at our earliest convenience because we do get thousands of certificates. So just be patient. We'll get back to you in a few weeks. If you guys like need the specific email address, the guidelines of how to write summaries, what to do, and everything and all that is all in our bio and on Instagram at official Club Med. So make sure you guys go check out the guidelines. And it has all that information in there. Second thing, we ask that you guys like and subscribe the videos to so we can because here's why we ask you to subscribe, because it'll notify you guys when we go live so that you'll never miss a session. So that's like really convenient for you guys, so that way you'll like never miss a session. So that's convenient. So now I'll go ahead and get started now that I got all the formalities out of the way. Yeah. Today we have Rashadah Jordan, and she is a psychiatry PA, and we are very excited to have her here today, and I will let her introduce herself.
Yes. Hi, everyone. Before I get started, I just want to thank you for creating this platform and giving me the opportunity. I love doing presentations. I love talking to pre-PAs and motivating people and encouraging people. I get excited because you guys are excited. So it's a great energy. So I'm happy. I've been waiting for this all day. So thank you for having me.
We are so delighted to have you. We're honored.
I'm excited. So my name is Rashadah. I'm a new grad PA. I've been practicing for 2 years here in Roanoke, Virginia, and I do outpatient psychiatry. And so today I'm going to go through a presentation where I'm going to give you some more information about me, my background, what it was kind of like for me going through PA school. I was a part of a first class and all that good stuff. And then I'm going to get into some technical work. So I know on my stories, on my page, if you guys follow me, I have listed, and I was like, get your NCIS on, get your Law and Order on. We're going to get into some stuff. So I'm excited. So I'm going to, we went over this before we started, share my screen. And I'm going to get right into it so that I don't waste you guys' time. I'm on Eastern Standard Time. I don't know what time you guys are on, but I know sometimes it's kind of late. So I don't want to waste your time on anything. Can you guys see? Can you see it?
Yep, it's perfect. If you just want to full screen that. And if you guys have any questions during the case study or during the background, just go ahead and drop them in the chat and we'll try to cover as many as we can during the Q&A, just to go over that again. But
okay, so again, my name's Rashadah Jordan. I'm a PA in psychiatry. And a little bit about me. So I started out in public health at Coastal Carolina University. Go Shants. I'm originally from Newark, New Jersey, but I relocated to South Carolina, completed all of my schoolwork. And then I think it was my senior year of college, I started applying to PA schools that summer before my senior year started, got accepted into Francis Marion University. Now, guys, I know it's highly competitive, and nowadays we have like all this stuff going on with applying to PA school, but please don't get discouraged. Please keep going. When I went to PA school, I had nobody to talk to, nobody to ask for guidance, and I still made it. So if I can make it, you can make it, but I'll get into that later. So I got accepted into Francis Marion, graduated in 2018. here are some of my certifications. I have my basic life support, advanced cardiac life support, and then I have my CAQ psychiatry. So that is a specialty certification that PAs can get in psychiatry and surgery. I think pediatrics, emergency medicine, and some of the other ones. It's an extra exam that you can take once you've been in your specialty and gotten a certain amount of hours, a certain amount of continuing education hours. And so after that, you take this exam. Now, it's not as bad as your boards. It's only 2 hours, and it's just with your specialty. So that was better, but it lasts for 10 years. So just to give you a little bit of background on that, I don't know if you guys ever had a PA that had a CAQ certification, but just had to explain that to you. Mm-hmm. Cool. Okay. So I'm in private practice. I think I told you guys that I work for an outpatient clinic. I work 8 to 5 every day except for Friday. I work from 8 to 12 on Fridays. I do telemedicine. So just like I'm talking to you guys right now, this is my life every day. I don't use the Mac, but I know you can't see it, but I have a whole setup like right here where I see patients every day. I see group homes, I see foster care, I see teenagers that were in detention. I see a little bit of everybody from ages 5 and up. The cool thing about my job is we do foster care, like we find children placements. And we also work with kids and the correctional officers and things like that, probation officers and things like that through my job. So I get exposed to a whole bunch of things. And I work very closely with DSS. So that's some of the things that I do with my job personally. These are my most common disorders that I see in psychiatry. Anxiety, of course, especially last year in 2020, right? Depression, of course, bipolar disorder, ADHD. I see a lot of adult ADD that's missed a lot, especially inattention is ADD, inattention, because these are the kids or the adults that do great when they're younger and they start having problems studying in college. And they start to notice it's not as easy to study. You get easily distracted, irritable, all sorts of stuff. And so we find out they're ADD. But the sad part about it is about the time you get over the age of 17, mostly over the age of 13, insurance companies will not cover stimulants. So that's the hard part. So you only like what you have to choose from is very slim. So, but I see that a lot. I see ODD, oppositional defiant disorder in the kiddos, and that later on can turn into conduct disorder, which is that times 500. And personality disorders, if you want to take it a step further. Schizophrenia, I see schizoaffective disorder, which we're going to get into that in a few. Of course, I do substance abuse, so marijuana use, cannabis use, meth. There's a lot of meth use nowadays, opiates, heroin. I'm pretty sure all of us is familiar with the opioid epidemic. And then alcohol use disorder. And then a lot of people don't think about this, but nicotine, caffeine use, also disorders.
Just a real quick question. There was a question someone asked, and that's, what is the difference between ADHD and ADD? I noticed that you kind of covered that. So just let's.
Oh, yeah. Yeah, so anytime you guys have a question, just drop in. I'm here for you. So yes, so ADHD is attention, like it's the hyperactivity part. So it's the kiddos that can't sit still, can't stand in line, can't wait their turn, excessive talking, impulsivity, like it's a lot of that. Whereas ADD is a little bit more settled. And I'm actually in school right now. I'm doing my project on this. So ADD is kind of, I won't say it's not an issue. It's like the kiddos that are younger when you're in elementary school and you talk a lot and your teacher's always writing like home to your parents, like they make good grades, they just don't shut up, like they just keep talking, they just won't be quiet, they're always interrupting class. And then when you get older, you have a little bit more trouble focusing. You start to notice you don't study as well as you used to. You can't grasp the information, like you can read something from a page and within the next few minutes you forget what it said. Or you're failing, your grades are starting to slip, things like that, very noticeable things. Or I have ADD, so I know, like I'm looking for my phone and my phone's in my hand. You ever had that moment? Yeah, so you start to see little things like that, and you just like, okay, it's not as severe, it's not as noticeable, which is why it's a problem. Because if you don't treat ADD, which is more inattention, so you're not hyperactive, but you have problems just focusing or staying focused for a long period of time, it can cause a decline in your quality of life, meaning like in your social life, in your academic life, in your occupation, whatever job you have or trying to hold, it causes problems. And when people start to fail and they don't know they have ADD, they blame themselves, and then they start to become depressed, and it's like a snowball effect. So I hope I answered your question.
Yeah, that was perfect. Yes, perfect.
Okay. All right, guys. So I wanted to put this slide in here because I feel like it's very important. I have talked with so many pre-PAs and people who are interested in psychiatry, but I want to let you guys know psychiatry and psychology are two different things, okay? Two different things. Psychiatry is medicine. Psychology is like the patterns and the behaviors and studying the mind. They go great together, but they're two totally separate different things, two totally separate trainings and degrees, okay?
I had no idea, so thank you for clarifying that.
Yes, I get that a lot. I'm like, no, no, and we do not do therapy, okay? This is medication, period. So one of the things to consider if you want to go into psychiatry, you have to know that this is a delicate specialty for many reasons. Number one, a lot of communities, especially the African American community, think that psychiatry and mental health is taboo. And I guess a lot, not just the African American community, but a lot of older adults, mental health wasn't something that people really talked about back in the day. It was something that people were ashamed of and hid. And it was horror stories about how they were treating people with mental health issues, how the type of medicines they were putting them on, and people are afraid. So when they come in and they consult with you for medication management, you need to be as personable as possible, as non-judgmental as possible, but you also have to show your compassion. So your empathy, not sympathy, but empathy for the patient. You have to learn how to listen to the patient. You have to provide resources to the patient. Whatever job you work at, if they have like patient pamphlets that we usually see in the waiting rooms, but nowadays we're working from home. So if you know any website you could refer them to, or anything that might be easy for them to find to educate them if you can't get all the patient education out during the session. You have to watch your interactions, not just between you and the patient, but the patient and their family members, like the dynamics between them and people in the room. That's how we pick up on child abuse or elderly abuse or anything that just don't seem right. And of course, we're mandated by law to report to CPS or the authorities if we're concerned about anybody's safety or anything like that. Know that you are a part of an interdisciplinary team. So you don't work by yourself. You also work, of course, with your supervising physician, but you work with their primary care provider, their neurologist, their cardiologist, their pulmonologist. Like you work with every specialty or specialist that they see for their problem. Endocrinologist, like some of the psychiatry medications that you can start someone on can cause issues in their thyroid and so many things. So you're actually part of a team and you're like communicating with their providers, you're emailing, you're faxing, you're calling. So that's important. And then my favorite one is learn how to say no. You're going to get people in your office that's going to try you. Some people do not have psychiatric issues, or either they do, or they might just have a clear substance problem. But because they come to you, they're just like, oh, I really need Klonopin, or I need Adderall, but you have to justify and clarify. So it's a lot of investigating in psychiatry, because I'm sure, like, I don't know if you guys know or not, but in psychiatry, we don't have a physical exam. I mean, we will do an objective exam, look at the way you're speaking, your affect and everything like that, but we're not going to listen to your heart or like unless I was inpatient, but being outpatient is a little bit different. I'm not actually touching and assessing the patient. The only thing I have to go off of is what they're saying. And people lie. So you have to learn how to say no if you don't feel right. But those are just some things to keep in mind. Okay. And yes, malingering. So that was what I was talking about. People that are fishing around for what they want. Family dynamics and body language is huge. So if you have like parents that come in and do all the talking and the patient isn't talking, you kind of want to talk to the patient. Don't let the parent take over, that type of stuff, because if their body language is suggesting that they don't feel safe or that they're a little shy or that they're fearful, you kind of want to watch out for that one, because there's certain protocols I'm pretty sure my job takes, and I'm pretty sure other people's jobs takes when something like that is going on. So, okay. Any questions I have so far, my love?
We have a lot about schooling. So here's just a couple if you want to just like skim over it real quick. Did you take a gap year, or if you didn't, like what would you suggest doing in a gap year? Some more questions were how many PA schools did you apply to? And like how was your journey regarding schooling? Like before we go more into the job aspect, like just cover the school aspect.
Yeah, so I don't want to discourage anybody. I don't, because when I tell you guys this story, I do not want you listen to me, guys. I do not want you to compare yourself to me, okay? I only applied to 2 schools. Now, when people hear that, they're just like, but I know nowadays PA school is a hot commodity and everybody's applying. The less people are going to medical school, people are coming to PA school, they're becoming nurse practitioners. I know it's highly competitive, okay? It's highly competitive. I applied to 2 schools. I applied to Augusta PA program in Georgia, and I applied to Francis Marion. I got rejected from Augusta with the swiftness. I did not get in. I think that their priority was to give first dibs to in-state students. So of course, since I didn't live in Georgia, and then I applied to Francis Marion University, which was a brand new program just starting up. I got all my stuff in for early decision. I was a part of the first interview process. I had my interview on my 21st birthday. And I went straight into school. I did not stop because I didn't trust myself to come back to school once I had a break. I didn't stop. But I know I've been getting that question a lot because I have mentees and they have asked, would you recommend a gap year? And I'm just like, well, if you've worked yourself to death in undergrad and you've been in 5,000 clubs and you never take a break and you feel like you're tired and you're go, I would urge you to literally sit and think about your mental health. It all depends on you. Do you think you're going to be able to handle PA school going straight from undergrad in? Because once you get in, you're on that hamster wheel for the next 27 months. My program was 27 months, and you do not get a break. I know that my first year we had summer break. No, not summer break. We had fall break, and we had some type of 1 or 2 week break up in the spring or the summertime. That was it. We went to school all year round. Once rotations start, all year round. Once you get close to graduating, you're getting ready for boards. After that, or shortly before you graduate, you're looking for jobs. And then after you pass your boards, you go straight into work. Where's the break? Like you're going to be running, you're going to be testing, you're going to be quizzing. Like you have to know when to listen to your body and when to break. So if you feel like you're not the type of person that's going to handle stress well, I would urge you to probably take a gap year, and you should know yourself well enough to tell if you need a gap year or not. Because PA school, there is no time, like it's not.
No, I didn't think so. Once you're there,
yeah. Once you're, it's going. Like, not to scare anybody, but I remember when we learned cardiology and pathophysiology, we had 1 month to learn everything about cardiology, including EKGs. And if it was any test during PA school that I felt like I was going to fail, it would have been that one. I was scared to death. I did CNA work before. That was my patient care hours. I took care of the elderly people, which I love. But I didn't have any experience reading EKGs before that. So we had Dubins to learn literally during winter break, which nobody, I mean, during the time they're just like, I want to spend time with my family. I'm not really, so I looked over Dubins, but did I remember everything I read? No. At the time I was ADD and I didn't even know it. So I was beating myself up because I thought I wasn't studying hard enough, but really I needed medication. But yeah, it was hard. We had over 2,000 slides for a test, and we had just finished our last PowerPoint that Friday, and the test was Monday. So I literally studied all weekend. And at the point of PA school, I didn't really know how to study until I was close to graduation. So it's all about like learning what's important, what's not important, and knowing how you study. That is so important. Learn how you study, but know what you can handle. And if you feel like you're going to fold, I would take a break then.
Right. And it's a good thing that you're being completely honest, because it's not always a walk in the park, and
No,
like we're not going to sugarcoat it. Like it is like the hardest 27 months, but
it's worth it. It's worth it. I mean, the look on your patient's face when you diagnose them or they have a problem and they come back better, you're going to be so proud of yourself that you stuck it out. But if you're doing this for the money, or if you think it's going to be easy, you're going to fold. You have to have a real reason for why you want to be a PA or a doctor or anything in medicine, because you have people's lives in your hands. Legit. Even though I'm not doing surgery, I have people's lives in my hands. People want to commit suicide and they're depressed and things. They're depending on you, and you have to actually learn the information. So not just pass the test, but you got to know what you're doing. So yeah, please take a break if you think you're gonna fold.
right. Like there's no reason to just put yourself through all that.
Yeah, and there's nothing wrong if you do take a break. I have plenty of friends that took a gap year. I was the youngest in my class. Everybody else had a whole life, career, kids, husband, a wife, everything. I was the youngest one. I was only 21. I turned 22 shortly after starting. So yeah, I bet y'all are like, so how old are you? I'm 26. I'm 26. Yeah. Oh my gosh. So do I look about 15? I'll take it. I'll take it.
Wow, that's the youngest PA we've ever had.
Yes, I've only been practicing for 2 years. January made 2 years, but I love what I get to do. I love what I get to do. And I love teaching. I think when I get old, I'm going to teach. But yeah, any more questions? I don't want to waste no more time.
There was actually a more sensitive question, and of course you don't have to answer it if you don't feel comfortable, but have you ever experienced racism in the workplace? And if you have, how have you addressed it in a manner where you didn't like lose your cool, or because like I know I probably would have lost it.
Yeah, so unfortunately, yes, it's going to be there. It's everywhere. So in the workplace, you kind of like, for my first job, when I got there, I wanted everybody to like me. So at first I was kind of sucked into being a yes person and doing it with a smile and acting like any type of comments or anything offensive that I heard didn't bother me. But that started to take a toll on my mental health because I was ignoring it, and I would be mad at myself because I didn't I didn't stand up for myself. And I was expecting somebody else to do it, like one of my colleagues, because they heard it, so they knew it was wrong, but they didn't stand up for me. And then after a while, I was like, listen, all you have is yourself. You are the first Black and the only Black that they have ever hired in this position. And even patients had to get used to seeing a Black provider because I'm in a town that's not used to that. It's not minority friendly, or it's minority friendly, but they're segregated. I hate to say that, but they're all in their same little place. Like you go there, we go here type of thing. Like it's old. And I'm not from here, this place in Virginia. I'm from South Carolina. And even though South Carolina has its own history and battles, but it's not like that. Like not, I felt out of place here. So long story short, I had to start getting some balls and I had to start advocating for myself, not nasty, but I had to learn how to be nice, nasty, if you know what I mean.
Right.
So it's just kind of like when somebody disrespects you, you'll just be like, you just prove them wrong with your work ethic. So I had to really show people that I knew what I was doing. You're not going to put me down because I'm a minority. I'm not less than you. We're equal. We both have the same degree, and I'm going to show you. So after a couple of months, all of my patients loved me. All the new patients that came to see me, they got nothing but good reports. My notes were done. So it's true when you hear we have to work 10 times as hard as our counterparts, but we do. I'm the only PA in my practice that have the CAQ certification. And I did that because I had to show them that I'm capable of doing it. Doesn't mean I'm better than any of the other PAs, and it doesn't mean I know more, because I'm still learning every day. Medicine changes every day, and the moment you get confident is the moment, I get scared. Like, you're never supposed to be like big ego, big confident in medicine, because that's the moment you mess up. Like, you're always supposed to be humble. So of course, I had to do what I had to do to prove a point. Now they respect me, but it wasn't easy, and it did take a toll on me. So yeah, I do face it.
Incredible, honestly, like that, like being able to stand up for yourself like that and to set an example, because you are the first. I can't even imagine. That is incredible. And everyone in the comments is just like, they're blowing it up. Like, they love you. They're like, you're amazing. They wanted me to tell you that. Like, the comments are incredibly positive. They love your mentality. But thank you so much for addressing that. Like, I know a lot of our people that shadow are people of color, and hearing these things can encourage them. So I'm thankful that you spoke up about this. But thank you.
Yes. Learning, just knowing how to say things, not to where you'll lose your job, and they're expecting you to get angry. They want you to act out. They want you, but you don't ever do that. You just smile, and you use those big vocabulary words, even if you have to Google them, and you just write a nice, nasty email, and you just be like, yeah, I'm sorry that you feel this way. However, you do what you have to do respectfully, and then just say, thank you, have a blessed day,
Mm-hmm.
Yeah.
Love it. Oh man, everyone loves you. Like, they love your mentality. It's awesome. Lots of love in the comments right now. But
Okay. So gotcha. All right. So if there's no more questions, I get back to it, because I know we only have an hour, and I know people like go to bed. I'm a grandma, so I'm in bed by 11. So I'll tell you. So clinical assessment, we got to the clinical part. So the most important thing in psychiatry, because I told you guys earlier, we don't have a physical assessment, is taking their word or knowing their history. That's really, really important, because so many psychiatric disorders are hereditary, especially bipolar disorder. I see that all the time. So knowing their past psychiatric history, their previous providers, their previous medications, and did they work or not? Did they have an allergic reaction? How long were they on it? If it was 100 years ago, would you be willing to retry it? Anything you have allergies to? Have you ever had inpatient treatment, been in a residential, been on a psych unit? Have you ever had previous suicide attempts? Have you ever had a family history of suicide attempts, a family history of anxiety, bipolar, schizophrenia, and substance abuse? Now, sometimes people are not honest about their substance use. So before, like anytime I have a new patient on my schedule, before I even see them, I have my admin take them to go get a drug screen. And if they can't do it, if they get busy, I step out and I take them to go get the drug screen, because we're all a team. So we all work together. So whenever they're busy, I'll step in and I'll help, fill the gap. So I'll take them to go do a urine drug screen, and not being judgmental. But if I feel like my spidey senses tingling, I will be like, do an oral swab, because I know people, sometimes they'll be like, oh, I can't pee, or I can't. And I'll be like, no problem. Stick this in your mouth under your tongue until it turns blue, because you really want to see what's in there. The only problem with the oral swab is it takes about a week to come back or so. Urine drug screen, you can pretty much look at the cup and see the lines, what's positive, what's not. But even so, I take that to the lab and they do a confirmation on it just to be more in depth, just to make sure I'm not missing anything. But yeah, just making sure you get all these is the most important in the history. And you want to make sure that you ask all relevant questions. So depending on their age, depending on what their chief complaint is, and depending on how you feel, like how they're coming across to you, the vibes, you want to ask all the questions. But even if it's something that I know may or may not pertain to them, I won't know until I ask. So I ask everything. I start at anxiety, depression, then I go into mood, psychotic, appetite, sleep. Like I have a whole outline that I go down, and I go down everything. And if they say anything that sparked my interest, I go down another avenue. But you really want to make sure in your first initial appointment, you cover everything. This is important because this is how things get mixed. This is how you mix up and you diagnose somebody with depression and they're bipolar depressed. This is how you make mistakes like that. So you really want to make sure you know your stuff, you know your questions, and you ask. You want to make sure you're listening, because what they'll say is they'll say like, oh, well, I took my medicine Monday, but I haven't taken it since Monday. And then the next couple of minutes, you'd be like, yeah, so how long you been taking it? Yeah, I took my medicine yesterday, but I feel like it's not working anymore. Well, did you take it Monday or did you take it yesterday? Like knowing to listen to them and ask questions, because sometimes things don't add up. And yes, like I just said, always decipher between depression and bipolar depression, because it's missed so much. It's so much. That's a problem. Okay. This is the objective examination. So I just copied and pasted this in here. You always want to document their appearance. You always want to look at or ask them about their orientation, person, place, time, behavior. Like, are they a cooperative? Are they sitting up? Are they engaging with you? Are they distracted? What's their speech like? Somebody that's in mania, they're going to talk like 10 miles per hour. Somebody who, is ADHD might be all over the place, or they might ramble on. So you have to decipher what their speech is. Emotions, so their affect, is it flat? Does it match the mood? Are they depressed? Are they angry? Their perception, their thought process, do they have loose associations? Are they delusional? Are they psychotic? Concentration, is it impaired, poor, fair? Memory, insight, judgment. And if you question any of this, like orientation especially, you can do a mini mental status exam. That's not something that you will always do. Sometimes we refer them to neurology if we're concerned about dementia or Alzheimer's or anything like that, but that is something that we're trained on. But I have yet to treat Alzheimer's disease or anything pertaining to memory loss or anything like that. I usually refer to neurology because I know that's out of what I do. But then again, it is how we're trained. So, I mean, if I wanted to treat it, I could, but I haven't done that yet. In my little 2 years, I haven't done it yet. I would definitely say if it's a geriatric patient or an older patient that that they come in and they're always on it and they're sharp, and then one day they come in and they're confused and they don't know where, then you can do one. Yeah, that's kind of like my rule of thumb here for now, as I continue to get more experience. Okay, so any questions before I get into the case study?
There was one really good question that I saw in here. What are your thoughts on the risk versus benefits of medications, and what happens if a patient becomes tolerant or dependent on them?
It depends, because I mean, the only patients that I really have a concern about becoming dependent on medicines is pretty much the controls, like the benzos. And I rarely prescribe those, like Xanax, Klonopin, anything like that, because I have to really trust you and know you. Like I said, I'm very suspicious. I protect my license at all costs. So you're going to get a drug screen from me. Like before I even put you on a benzo, you're going to get a drug screen. But before I even prescribe something like that, I have to at least know you good. Like I have to be seeing you for a good while, because once you make that mistake and start prescribing that medicine, they're going to want you to keep prescribing it. And then I've even had some people say, oh, you're going to stop it? Well, I'm going to have a seizure. Like they'll try to guilt trip you. But if the benzo isn't that high, then like if they're like on 0.5 once a day, they can't have, I mean, I guess technically, well, you could. I can't say that you can't, but I doubt it. I doubt it. But they'll try to say, oh, I'm gonna have a seizure, I'm gonna sue you or something, I'm gonna call the medical board. And I'm just like, okay.
All right, just do
But
it.
yeah, I'm just like, okay. But yeah, so I don't prescribe enough medicine like that for them to become dependent or tolerant. I monitor them like my life depends on it. I'm watching that VA PMP for Virginia. I check and look at all the control drugs they've been getting, even if I don't prescribe it, opiates, anything. So I can make sure I'm monitoring them. And usually after I get the first drug screen, I get to know them. I usually start doing it like randomly every now and then. I keep doing it and I monitor them just to make sure if they're on anything controlled or not. Because sometimes if you're using drugs and you withdraw, like let's say you can't get high today, we know marijuana can cause irritability and anxiety when you're not high. When you're high, it causes euphoria and disassociation, right? So like if I'm sitting here trying to help you control your anxiety and your moods, and I'm thinking you have a mood disorder, but you weren't honest with me and you're out here using weed all of a sudden, I can't control your psychiatric issue because you're still using drugs. The problem is the drugs. So yeah, just making sure you're not being fooled. But if I do start something controlled, I'm monitoring them very closely. And I always let my patients know this is not going to be monotherapy with a benzo. There's too many anxiety medications out here. I'm not just going to give you this by itself. And you are going to come down off of this within a couple of months. This is not long-term treatment. I let them know off the bat, because Xanax and all that causes cognition issues and things like that as they get older, and you just don't want to be reliable for any of that stuff. It's very easy to be sued out here. Right. Yeah. Any other question?
I think we're set for now, but if I see any more ones, I'll.
Okay. All right, so this is my case study. I hope y'all ready to put on your FBI hats. Yeah. So the chief complaint is, I feel depressed. Let me move you over here. Da-da-da. Okay, so 45-year-old male presents with concerns of low energy, isolation, low moods, hypersomnia or excessive sleeping, and loss of appetite. Patient reports he has been feeling depressed for the past few days. Patient reports last week he had a decreased need for sleep. So he was very goal-oriented behaviors. And I know I'm using language you guys aren't used to, but like OCD-like behaviors, excessive cleaning at nighttime, can't sleep, energy all the time. Expansive mood means like euphoria, you're happy, you're giddy, you're all over the place. And he admits that he maxed out all of his credit cards and he has impulses to abuse marijuana and alcohol and occasionally use meth because he can't focus. And then the patient reports racing thoughts, mostly at nighttime when he's unable to sleep. But then he experiences also visual and auditory hallucinations, which, he sees people or things, objects that's not really there, hear voices when nobody's around. And he admits most of the time he feels like people are after him. So he's very paranoid. And the patient admits he sometimes speaks rapidly and he has disorganized speech. So I said a mouthful, and I'm pretty sure you guys are like, what in the world is going on?
There's a lot of guesses, actually. I can say some for you.
Yeah.
People are saying bipolar. Mostly I'm seeing bipolar. I'm also seeing schizoaffective disorder, ADHD, manic depression. Sorry, I'm like, I can't talk.
No, you're fine.
Someone said personality disorder. So those are the ones I'm seeing a lot.
Okay. I got you. So I'm so excited. So what do you do next? What do you do next? So being that they abuse the drugs, we got that has to be the first um where you start first. So you need to ask the patient, how much are you using? How long have you been using? How bad is it? Like, are you still using drugs? Like, if the patient is employed and they're still using drugs knowing that they can lose their job, or if they're spending their money that they have for bills and for food on to get drugs, or if if they build tolerance and they're finding that they're using more, or they went from weed to cocaine or something, like it's getting worse and worse, they have a substance abuse disorder. So then you have to decipher, is what's going on coming from the drugs, or is it coming because they truly have a psychiatric disorder, right? So I'm pretty sure you're like, so what do I treat first?
Right. I'm like, where do I start?
It's loaded, right? So if I was in the situation and I was in practice, I would say, okay, I would make sure I get a good family history. So anybody in your family have bipolar disorder, schizoaffective disorder, schizophrenia, anybody like your parents, your mom, it has to be mom or dad, first line relative, because that's where they're going to get it from. It has to be hereditary. It's not going to count if it's cousin, uncle, auntie. It has to be mom or dad. And it'll make more sense if grandma has it and then mom had it, then that, just to see the pattern, see it come down the line. So that makes sense. And then after you get all that together, you have to ask them, well, when did this start? Like, did you just start feeling paranoid, or when do you notice like all of this first began? Sometimes in their early 20s, that's usually when we see schizophrenia kind of come about. But I've even had some patients where schizophrenia has come about in their teenage years, no younger than that, because that's just no. But I mean, some like they're into their teenage years, like 17, 18, 19, 20. I've diagnosed some people with schizophrenia because they have very strong family history of it. So that's where I would start: substance abuse, family history, make sure you're getting all the good background information. After that, I would go ahead and get into referrals. So, but before I get into that, this was the labs and objectives. So vital signs was within normal limits, labs was within normal limits, UDS was positive for cocaine. So I don't think he told me about the cocaine. Cocaine, meth, and marijuana, oral swab pending. Appearance is unkept. So usually in schizophrenic patients, they are unkept, like they're disheveled looking. The speech was regular, rate tone, so he wasn't in a manic episode at the time, because remember, right now he's depressed. He was cooperative. Depressed, affect is flat. Usually in schizophrenic patients, we see flat. Concentration was poor, fair, needing redirection. He had a kind of a disorganized thought process that we usually see that too in schizophrenia. So diagnosis is schizoaffective. So I'm happy that somebody said that. But I know earlier I said it's hard to decipher between the two, right? Mm-hmm. So hypothetically speaking, our patient, during the time I made a referral for IOP, which is intensive outpatient program for drug use. And I went ahead and started treating him for schizophrenia or schizoaffective disorder, but we treat them both the same. So schizoaffective is bipolar and schizophrenia together. You have to, in order to diagnose schizophrenia, you have to have either the delusions, the hallucinations, or the disorganized speech. There's other criteria, but one of them has to be one of those three, and then you can have negative symptoms and everything else like that. But for this person, they had the hallucinations and the I didn't put it in there. I put disorganized thought process. I should have put disorganized speech, but I think I put it in there, not sure. But you have to have one of those. And then they had all the symptoms of bipolar disorder. They weren't sleeping. They had the OCD, or the excessive goal productive, goal oriented, euphoric phases. They're maxing out, spending all their money. They're abusing drugs, trying to control it because they're not medicated. Had everything. And usually in bipolar disorder, it's an umbrella term. It's not just a disorder. It's an umbrella term that has plenty of symptoms up under it. And you think 1,000 things are wrong, and it's just one thing. So when your moods are not stable, You have trouble sleeping, trouble concentrating, you have mood swings. Some people go from irritable to depressed, but then some people go from irritable to depressed to euphoric to expansive. Like they just go up, down, this way, that way, this way, that way. Usually type 1 bipolar disorder, which is manic. They have to have a manic phase to be diagnosed with that, which is qualifying as staying up for several days in a row without sleep or needing little sleep. So if you can sleep for 2 hours and still go for 7 days, something is wrong. Like your moods aren't stable. Or if you're excessively cleaning your kitchen and you just cleaned it yesterday, or if you're so OCD to the point somebody come in your room and move something and then you want to fight them, or you're punching holes in the wall, or you're getting in the fight, so you're, it's a spiral. Like you're just spiraling out of control. Usually that's an issue. So if I had to treat this patient, this is what I would kind of diagnose them with: schizoaffective disorder. If I was unsure, I would just put the ICD-10 code F39, so that's mood unspecified. And then I would probably document in my assessment, most likely schizoaffective. Like if they were a poor historian, didn't know their family history at all, and this is all I had to go off on, this is what I would put down. Definitely cocaine abuse dependence, questionable, because I don't know if they were a poor historian, if they weren't able to tell me or remember. Depending on what mental state they're in, that's what I would put down, like cocaine, THC, amphetamine, abuse or dependence. And then, of course, confirm the level of tolerance, how long, what they've been using, etc. Always evaluate the skin on the patient. I know that I said we don't touch the patient, but if you can look at them really good, make sure you're looking at their body language, but also their arms, the skin, like if it's not covered, if you're worried, like if they're using that, if you're worried about their honesty, if they might be shooting up using IV drugs or anything like that, you definitely want to look for track marks. You want to look in their mouth. Usually meth users have the meth mouth, we call it meth mouth, but that's not a good thing. They have a certain look, but their teeth are all bad, like decayed, and they look a certain way. Or meth, they pick at their skin, because when you get really you oversaturate those receptors, you don't know what to do. Some people feel like zombies, some people pick, like they have to pick at their face or their skin somewhere. So just making sure you're looking at them. What do they look like to you? But yes, this is how I would go. I would refer them to intensive outpatient. Usually at my practice, if you don't get intensive outpatient treatment or some type of substance abuse treatment, I cannot continue to treat you without that. I need you to get in the program, because we have to get you clean first and see you at baseline in order for me to truly, truly, truly know what your symptoms are without the drugs in your system. Right. If you're not willing to do that, if you're not willing to go to counseling, or you can't get into the IOP program, then we can refer you somewhere. If you're not willing to participate at all, I'm sorry, we might not be the practice for you, because I have to see you at baseline. You have to be clean. Now, we all know that using drugs is relapsing and remitting. You use drugs, you're clean, and then some people might relapse. You use drugs, you're clean. Some people might stay clean after the first time. Some people might not. It just depends. It's different for everybody. But we are not to, again, with the compassion and stuff, we're not to treat substance abuse like it's a moral issue or anything like that. We are to treat it just like we treat diabetes and everything else. We're not to make them feel bad or be insensitive to them using drugs. Most of the time, trauma and other things are contributing factors. But in this case, we're just going to take it for, his schizophrenia or schizoaffective didn't know, and it's out of control, and he tried to control it with street drugs. Of course, counseling. I refer everybody to counseling, because medication is no miracle. So you want to make sure, in addition to medication, you get them in counseling. And then, of course, we treat bipolar and schizophrenia, schizoaffective disorder with antipsychotics. So in this case, he's a male, he's using drugs and everything like that. I'll put him on Seroquel. I would probably put him on a low dose of Seroquel just to make sure he tolerated at first. And then after that, I'll probably titrate up. And then if he can tolerate that at immediate release, regular Seroquel, I'll probably switch him to extended release as he continues to get clean. And once he's clean, any lingering anxiety or anything that's left over from that, we can address one by one. But I don't start one and more medicine at once. And I don't start people out on a lot of medicine because that's what they're scared about. They're scared when they come to psychiatry, you're going to dope them up. You're going to put them on something that's not going to make them feel good and make them feel like a zombie. And you want, even if they are sitting up in your office high, you want to create a rapport with them and make sure that you're not there to judge them. You're there to help them. You understand them, and you're going to do this together. This is a joint thing. So I would recommend Seroquel. I would tell them all the benefits, all the side effects, what I think about it. I would recommend some other alternatives, and then whichever one they feel comfortable with, that's what they'll go with. But hopefully it'll be the Seroquel, and we'll just go from there. But that's usually what I would do if we were in office. Any questions, my girl?
I have one, like, just from like my personal knowledge. I know that you try to like create like a comfortable environment for them, like so that they that they trust you and stuff.
Yeah.
But have you ever had a case where you had to report like severe drug use or like a cartel type issue to the police, and like how would you go about handling a situation where you need to involve law enforcement?
I only involve law enforcement if the patient is a threat to themselves or somebody else, or if they were doing something like so illegal that I couldn't ignore it, like that type of thing. But I have never gotten the police involved, unless, I mean, I have in a couple of, when I was concerned about a child, I would call CPS, and then CPS would take it from there because they will open an investigation. But as far as like them dealing drugs or anything like that, I don't report it. It's completely confidential unless they're going to kill themselves, kill somebody else, or put themselves in danger or something to where I can't ignore it. But usually I don't report that.
Okay. I was like curious because I've never I'm looking at some of these questions. I'm trying to find one.
Okay.
Um have you ever gone through I don't recall the name of this syndrome, but it's like where you're learning about all of these things, or and you like self-diagnose, because like I know that like sometimes I'll just go on like WebMD and I'll be like, I think
Oh Lord,
all of
hypochondriacs. No, Lord, I've had a couple of those. And I think after I graduated PA school, because you have so much information up there, any little thing that you start to do, you're like, oh my God, I have so and so. Like,
I have
I
it.
think I was a, yeah, I think I was a hypochondriac for a little while when I graduated from PA school because it's too much knowledge. You know too much. You just know too much. But I mean, that's different because we were taught. Patients who didn't have any type of medical training and they're going on WebMD, Google, and they're just like, this is what I have. Or, ooh, I love this one. You started me on this medicine, but Google told me that this medicine can do that. I don't think I want to take this medicine anymore. I'm like, okay, I totally understand. I wouldn't want to be on anything or any medicine that could do that. But let me ask you that. Was that a .org or a scholarly article or a reputable source? Where did you get it from? You said Google. Was it WebMD? Was it Mayo Clinic? I'm like, okay. So that's what they said it could do. How are you feeling? Do you feel fine? Are you having that side effect? No. Well, if you're completely fine with staying on this and giving it a little bit more time, I'm completely fine with giving it to you. But if you absolutely hate it and you're scared to death about it causing this, then we can switch it to something else. And usually I just switch it to something similar and they're fine. But for the most time, I can talk them into it. I'm like, please don't. Please don't. You're going to, everything is cancer. Everything is this, everything. You're going to scare yourself to death. You don't feel that way. You're fine. And then after you talk them down, they're just like, okay, I'm sorry. Or, okay, I didn't mean to, and I'd be like, no, you didn't insult me at all. You had a question and that's what I'm here for. I'm here for you. Make them feel heard, make them feel comfortable.
Like
Most important thing.
yeah. Just a few more before we move on. But why psychiatry and why PA over MD, DO, nursing? Like, why did you choose your profession? Which I mean, like, I think you're a great fit. Like, this is like amazing. Like, I love this session so far.
Yeah, so I wanted to be an MD when I first started out. I thought I wanted to go to school, can't talk, go to school to become a pediatric cardiologist, but I didn't know PA existed. So I was a part of a pre-med program within my local hospital, and they had a PA come to speak one day, and I just thought, I think that's what I want to do. It's less school, it's less debt, less stress, and I get out of school before I'm 30. And then I'm just like, let's do it. I learned all the same things that doctors learn in 2 years. So you're trained the exact same way. Now, nursing is different. Nursing is like everything. Nurses will be your saving grace. They know their medicine, they know the protocols, they will save you. Nurses are your angels, okay? But if we want to, like, nurse practitioner is completely different because they stay on the nursing model, but we're trained like doctors. We were created to bridge the gap between physicians and patients. So we know what they know.
Mhm.
So I'm just like, if I can learn what I'm going to learn anyway in 2 years, why not? It might not be as intense. Each program's different. Well, let me not lie. It's intense, period, in medicine, period.
Mhm.
But I mean, you might have different experiences depending on what program you choose, because each school has a different curriculum. They might have a cadaver lab, they might not. So, and doctors get a chance to do cadaver labs, and you might not get that opportunity. So it just depends. But why not? Like, why not be done with school, out practicing, having a life? And that's why we rank #1 on US News
Yeah, I
for our
saw
job. Yes,
number one
we
STEM
have.
right now.
Yes, we're #1. We have perfect work-life balance. Not perfect, depending on the specialty, because
Right.
PAs can do surgery, we can do everything. But we have, for the most part, satisfaction, good life, work balance.
Mm-hmm.
Yeah.
There. Well,
So
thank
that's
you.
Oh, I didn't answer the second part. Why psychiatry? So psychiatry chose me. Like I said, when I went into PA school, I wanted to do cardiology, pediatric cardiology, but then I just like cardiology. EKG, not my thing. So then I decided, okay, I'm just going to do family medicine. Went on my psychiatry rotation, fell in love, made sure my elective was outpatient. My first was inpatient. My elective was outpatient psychiatry. Fell in love. The information came to me. I didn't even have to think hard about it. I felt like I was gifted in a way, because I was just like, I get it. It just come to me. So I
Mm-hmm.
was just like, I don't know. And my friend was like, you should go into the psychiatry. I was like, I don't know. And then that's what I ended up going in, and I never looked back. Now, when I get old or later on down the line, I do want to do OBGYN and family medicine and maybe urgent care later on. But
Mm-hmm.
yeah,
Feel like it's a
psychiatry
good
for now.
option. That's awesome.
Thank you.
I think we're good on the questions for now.
Okay. Okay, guys. What time is it?
It is 8:59. Time really flew.
Oh Lord, I talk so much. Okay, so I had a second one on there, but I'm going to be actually doing pre-PA pals or whatever. So I'll do the second case study on their presentation. I think that's sometime in February. We haven't scheduled it yet, but they go through YouTube too. But this is my contact. Let me move us over. This is my contact information if you guys have any questions. I am on YouTube too. I just started a YouTube channel when I was in PA school. I don't have that many followers, but I'm thankful for the 700 and some followers I do have. So if you're interested in
Go
any of my
subscribe.
content, check it out.
Yeah. Go subscribe, guys. I know you guys had a lot of unanswered questions, and I'm so sorry for that. But this is like really great session. I like adored it. But if you have any questions or you guys want to check out her Instagram, because I know a lot of you guys were asking about it, it's right there. Make sure you guys go follow. That's
Yes.
all good stuff.
Yes.
Make sure you guys like and subscribe again for notifications.
Yes.
We really appreciate having you on the our shadowing program. Um, Oh, did you want to talk about the sweatshirt and then
Oh, yes. So I have a mentoring program real quick, guys. It's called Dreams Inspire Life. You can go to dreamsinspirelife.com to learn more information. Our Instagram handle is the same thing, Dreams Inspire Life. It's 4 of us. We're 4 mentors led by passion, trying to help you guys get into PA school. And I'm actually wearing my shirt. I wore it purposely tonight. So perseverance is key to becoming a PAC. And it says, Dreams Inspire Life and PA physician assistant loading. So these sweatshirts will be available hopefully here soon. Subscribe to my not subscribe, follow me on Instagram or follow the Dreams Inspire Life page on Instagram. We'll let you know when we're dropping. We're just trying everything out before we actually sell it. So it's comfortable. It keep you warm, but I just wanted to let you guys know we do offer services, personal statement help. We'll talk to you, anything you need regarding PA school. So
I'm not even pre-PA and I think I want to go buy one. Like I'll just be like loading.
Oh, thank you for loading.
But, again, guys, thank you so much for joining us. We really enjoyed having you. And I know a lot of you guys are asking when the next session is. We will be posting details for the next session for next week on our Instagram here soon. It is another PA. It is a dermatology PA, so that's another really cool specialty for you guys to explore. But again, Rashadah, I just want to say thank you so much for being here with us today.
Yes, thank you guys for having me. I enjoyed each and every one of you, even though I can't see you, but don't give up on your dream for applying to PA school. It will happen. Your journey is your journey. Your process looks different than everybody else. Protect your mental health. If you're comparing yourself to somebody on Instagram, block them, delete them. Okay. So you don't need anything that makes you question yourself or your journey or where you are now. You're where you are, and it's gonna happen in due season. Just keep pushing. Yes.
Well, thank you so much. I'll be DMing you.
Okay.
Thank you guys again. I will